All right, we are up and running. We're going to try this again. It's my pleasure today to introduce Dr. Sean Virani as our guest speaker for Grand Rounds this morning. Dr. Virani is the interim president and CEO for the Provincial Health Services Authority in BC, the head of cardiology at Providence Healthcare, the physician program director for the Provincial Heart Centre at St. Paul's Hospital, and a professor of medicine at the University of British Columbia and president of the Canadian Cardiovascular Society. He completed his internal medicine training for internal medicine and cardiology at the University of British Columbia before subspecializing in heart failure and cardiac transplantation at Stanford. He's completed a master's in public health at Columbia University in New York with a focus on healthcare management. His professional interests include public policy related to healthcare delivery, with specific reference to healthcare system redesign and quality within Canada. He's a key opinion leader for heart failure in Canada. He's the past president of the Canadian Heart Failure Society and senior co-chair of the Canadian Cardiovascular Society's Heart Failure Guidelines panel. He also serves as the medical director for Heart Life Foundation, which is Canada's first and only patient-led national heart failure organization. And on a personal note, I have known Sean, we've discovered now, for 20 years, and he has always been a great source of support and mentorship in my career. So thank you very much, Sean, for joining us today, and we look forward to your presentation.
Thank you for the very generous invitation or introduction and invitation, Ellie. Yes, we've known each other for a very long time. Dinner yesterday that I was multitasking as I was packing for Ottawa and realized somewhere over Saskatchewan as I was flying from Vancouver to Ottawa yesterday that I didn't pack a bow tie. And I texted my wife when I landed and I said, I didn't pack a bow tie. She said, they're not even going to be able to recognize you without a bow tie. So my first stop in Ottawa yesterday was heading to the mall. So hopefully it looks okay now that people can see me. I want to thank the University of Ottawa Heart Institute for the invitation. This morning, I look forward to presenting the latest update from the Canadian Cardiovascular Society and the Canadian Heart Failure Society for our guidelines updating the management of patients, care for patients who have an ejection fraction of greater than 40%. I'd like to begin, as always, by extending much gratitude to the First Nations of Inuit and Métis people of this land for their valuable past and present contributions. Specifically, I want to acknowledge that the land on which we gather is located on the traditional and unceded territory of the Algonquin and Anishinaabe people. The Algonquin people have lived on this land since time immemorial, and we honor their enduring connection to the land, waters, and community. Together, we reaffirm our commitment and responsibility as individuals to improving relationships with Indigenous peoples and to collaborating in a spirit of reconciliation. So these are my learning objectives for the talk today, but overall, what I can say is we have a new guideline for the management of patients with an ejection fraction of greater than 40%. And it's my aspiration today to talk to you a little bit about them and help you integrate these into your clinical care, to discuss the data that underpinned and some of the processes that were undertaken to develop these guidelines, and to answer questions as to how we can more effectively manage this patient population, which I hope to compel to you is one that is very high risk for hospitalization and adverse cardiovascular outcomes. These are my disclosures. So this is only a small part of the group of individuals that came together to develop the guideline on behalf of the Canadian Cardiovascular Society and the Canadian Heart Failure Society. I want to make special mention of these individuals. Many of you will know who these folks are because they're prominent figures in heart failure on the Canadian landscape. My co-chair, Dr. Shelley Zeroth, who's the other co-chair on the guideline from Winnipeg, as well as Dr. Eileen Omiara, from the Montreal Heart Institute, who led the section of the guidelines on SGLT2 inhibitors, Dr. Kim Anderson from Halifax, who led the section on MRAs, Dr. Stephanie Poon, who led the section on angiotensin receptor neprilysin inhibitors, and then Mike McDonald, who led the section on GLP-1 receptor agonists. I want to make special mention, however, of the other two folks on the screen, Dr. Farid Farutan and Dr. Natasha Alexova. They were our methodologists in this work. And this particular guideline, well, CCS does a tremendous job with methodology on all of its guidelines. I want to suggest to you that this was a particularly unique guideline in that we undertook meta-analyses that formed our decision-making with respect to these 4 different therapies, which I will go into greater detail on today. So full meta-analyses, really, really robust methodology went into this. So I want to thank them for that. And in fact, the meta-analyses are published separately because they're of such high quality. I also want to make special note and thanks to Dr. David Burney, who's in the audience here, and you will know well, who is the guidelines liaison from the guidelines committee at CCS, who supported this work, and the whole guidelines apparatus at the Canadian Cardiovascular Society, including Carolyn Gall-Casey and Dr. Carolyn Pullen, who's here as well, who's the ultimate sponsor of this work through the Canadian Cardiovascular Society. Takes a team to get these done. So the guidelines were published on October 18th, 2025. So we're now coming up to about 6 months since they were published, or a little over 6 months since they were published. And I really want to, again, acknowledge all the people on the screen, but I also want to bring your attention to the QR code, which hopefully the pointer is showing. No, the pointer's not showing. I'm going to try doing this, see if that works. Laser pointer. Ellie taught me well. Okay, there we go. The QR code on the screen. Because we've now developed a full suite of tools, knowledge translation tools and CPD around these guidelines. And so I invite you to download the QR code or go to the website and actually see these tools. This presentation today is really a first attempt at testing out one of these tools in terms of the slide set and getting your feedback in how impactful it is in terms of advancing your practice related to the delivery of heart failure care. So getting to the meat of the matter, I would say the thing that I hear most about these guidelines, or the feedback that I've heard most about these guidelines, is the nomenclature. So we've introduced a new term in these guidelines, and I look forward to a show of hands in terms of how people think this should be pronounced, because there does seem to be some differences of opinion. So historically, this patient population, those with an ejection fraction of greater than 40%, have been divided into 2 groups, and that's those with mildly reduced ejection fraction, so a group of 41 to 49%, and those with preserved ejection fraction, traditionally defined as greater than 50%. And this is embedded within the universal definition for heart failure, contrasting to those who have an ejection fraction of less than 40%, and historically that we've referred to them as those with HFrEF. In these guidelines, we have combined these 2 categories of patients, those with mildly reduced and preserved ejection fraction, into a newly defined category called heart failure with non-reduced ejection fraction. And I'm going to try and compel you that this makes sense from a patient perspective. So while there was rationale when the term was introduced for a group called mildly reduced ejection fraction, and that rationale was largely based on the fact that we didn't know much about that patient population, and we were working hard to identify to include this group of patients in clinical trials to better understand their trajectory, to better understand their prognosis, and to better understand which therapies they would respond well to. We really need to define them quite well. And that was really how that mildly reduced category was introduced. But what we know now, and what I will show you through the data that we developed through the meta-analyses, is that this group of patients with the mildly reduced ejection fraction performs and responds to therapy in the same way that patients with preserved ejection fraction do. That their clinical trajectory is likely the same, and as I said, their response to therapy is the same. And so now having these 2 different groups really doesn't solve much of a purpose anymore, but what it does do is it introduces confusion in terms of prescribing, it introduces confusion in terms of nomenclature, and it serves in many cases as a barrier to prescribing therapies for this class of patients. Maybe not for cardiologists or those who are practicing in the advanced heart failure space, But for the vast majority of clinicians, primarily, namely primary care, who do the bulk of prescribing and treatment of this patient population, it does create an artificial barrier to a better understanding of the patient's trajectory. And so what we have proposed is that these two groups be consolidated for clinical purposes in terms of prescribing and treatment into the group with non-reduced ejection fraction. And so then the question is, with a show of hands, is this pronounced heart failure non-reduced ejection fraction? No, how did Shelley put it? HEF non-ref. Is this HEF non-ref or is this HEF and ref? HEF non-ref, show of hands. HEF and ref, show of hands. I think the HEF and ref wins, and I personally am a HEF and ref person, but I think we have to figure out. Pardon me? HEF nerf, HEF nerf. I think we still need to land on that, but you may see me refer to it as HEF and ref colloquially through this presentation. As I've already mentioned to you that this off the top is this is a highly morbid disease that's associated with poor outcomes. And I'm going to suggest that to you both poor outcomes from a clinical patient perspective as well as poor outcomes from a system perspective. So we know that once you have heart failure, there is a heightened risk of mortality and heart failure hospitalization. And specifically, approximately 27% unadjusted 1-year mortality after any heart failure hospitalization. So this portends a really poor prognosis and is a high-risk marker in patients with heart failure. We know that patients, particularly those with an ejection fraction of 40%, have multiple comorbidities. They tend to be older adults and they tend to be women. And up until recently, there's been very limited treatment options. So if you go and do a member survey at the Canadian Cardiovascular Society and say, what area are you most interested in having clinical tools developed for? Invariably, one of the top 3 answers is going to be for patients with an ejection fraction of greater than 40%. People are always looking for guidance in this space, and that's part of the reason that we developed the guideline, now that we have some data upon which to draw that guideline recommendation from. In parallel, there is a high burden of this disease on the healthcare system, and it's generally considered as one of the most resource-intensive conditions in healthcare, and certainly in those who are elderly. 20% of patients with heart failure are readmitted within 30 days of their index hospitalization, and that can account for up to 2.8 rehospitalizations in the subsequent year. When patients are hospitalized, the average length of stay is about 7 days, and it's estimated in great work that was undertaken by Padma Cole in Edmonton that by 2040, this is going to cost about $1 billion Canadian to the healthcare system. So a really prime target for intervention, both in bending the cost curve for our healthcare system, as well as improving outcomes for patients. But because this heart failure hospitalization is so impactful, both from a patient and a system perspective, it became the key point of intervention for our guidelines. And so what I want to draw your attention to then, and just really skip to the chase here, is the central figure in that guideline recommendation. And I'm going to walk you through it in the next moment or so, but what I do want to highlight is that the guideline recommendation is to decrease the risk of heart failure hospitalization in patients with heart failure and non-reduced ejection fraction. So that is the outcome that we are trying to affect through this algorithm. Many of you will be familiar with the heart failure reduced ejection fraction algorithm that was published a number of years ago. And this is deliberately attempting to mirror that in style and feel so that people can navigate the two in parallel and have some level of comfort with it. You will see at the top the definition of the patient population that we're aiming to intervene upon here. That is those with an ejection fraction of 40%. They are symptomatic, and these are ambulatory patients as well. Yeah, I think with symptoms, turning my head because my vision is so poor that I can't see what's on my screen here. We make 2 types of recommendations. We make recommendations here that are highlighted in green. Those are strong recommendations. And we make recommendations that are highlighted in a pinky tone, although on the screen it comes out peachy colored. And those are weak recommendations. And we'll talk about the rationale for that as well. As mentioned, symptomatic patients in the ambulatory setting. We are specifically not talking about management of associated comorbidities, although there are many. And these were highlighted in a comprehensive guideline undertaken by my colleague, Dr. Ezekowitz, and the guidelines panel back in 2017. So I'll draw your attention to those guidelines if you're looking at specific recommendations related to comorbidities. We are also not talking about non-pharmacological therapies, of which there are many that this patient population would benefit from, including valvular interventions, coronary interventions, EP interventions, etc. And those are referenced in this guideline along the vertical columns that run along the side, but we don't specifically talk about those therapies. We don't talk about diuretic therapy. We don't talk about advanced care planning, all very important and all highlighted in the algorithm, but not specifically referenced in the guideline. What we do talk about, however, is 4 classes of medications: SGLT2 inhibitors, MRAs, ARNIs, and GLP-1 receptor agonists. For the first time in this guideline, we specifically reference patients who are marginalized in terms of socioeconomic status, marginalized in terms of rural and remote geography, and marginalized in terms of indigeneity. And we recognize that there may be systemic barriers to these recommendations that we're making, which may limit their uptake in those patient populations. And as a result, those individuals may not realize the same benefit as others for whom there is access. Any discussion of the guidelines, and specifically when I talk about the veracity and the methodology that was undertaken to develop them, needs to have a brief overview of what GRADE is. So GRADE is the methodology that the Canadian Cardiovascular Society uses along with the AGREE tool to support the development of the guidelines. David Burney, when I was here in November, I think, presented to the guidelines committee data that showed how good our guidelines compare and stand up to other international guidelines. And we perform as well as the European Society of Cardiology and better than the American College of Cardiology. Please tell me that was correct, David, when we develop our guidelines. So the methodology is sound and robust. It starts with the development of a PICO question, which looks at our population of interest. So in this case, those with an ejection fraction of greater than 40%. The intervention, so the pharmacological therapy, the comparator group, be that placebo or standard of care, and then the outcome of interest. So while this guideline is focused on heart failure hospitalization, we did perform meta-analyses and outcomes analyses of all-cause mortality, cardiovascular mortality, functional capacities by 6-minute walk test, Kansas City cardiomyopathy questionnaire in terms of quality of life. We went through the whole gamut of different outcomes of interest for these patient populations, and they are very well described in the appendix to the paper. And then there's 2 components to GRADE. Grading the certainty and quality of evidence for each PICO question and categorizing that as high, moderate, low, or very low. And that ultimately helps us to develop the strength of a recommendation as strong or weak. And you saw that in the original algorithm, whether the recommendation was focused in green or peach. Won't go into a lot of detail here, but only to say to you, if you have a randomized clinical trial, that generally results in high confidence in the data versus observational trials, which have low confidence in the data. And then you can have a number of things that are taken into account by the guidelines panel to then decrease that confidence or increase that confidence so that you end up with a final level of confidence rating that is high, moderate, low, or very low. And that then is listed in the recommendation. So what makes a strong recommendation? A strong recommendation is when the benefits clearly outweigh the risks or the hassle or the cost of a therapy. And what are the drivers of a weak recommendation? You can see them listed there, but if there's a balance, a close balance between the benefit and the harm, there's a low confidence in the estimate of the effect. The values and preferences that lead you to a weaker recommendation, and the costs, which results in 4 types of recommendations: strong in favor of, weak in favor of, weak against, and strong against. Okay, let's talk about the data. SGLT2 inhibitors. the rationale for looking at this group of therapies is overall there is pretty robust data that SGLT2 inhibitors improve cardiac function. I wish I could tell you how they improve cardiac function. There's certainly lots of postulates and hypotheses and a lot of mechanistic work that's gone into why SGLT2 inhibitors improve cardiac function. Everything from decreasing intravascular volume and blood pressure to improving myocardial efficiency. But what we do know is that they improve cardiac function and are associated with reverse cardiac remodeling. And that's likely through anti-inflammatory and antifibrotic effects, reducing oxidative stress, and improving endothelial dysfunction. Lots of data in patients with reduced ejection fraction, as well as those with coronary artery disease and CV risk factors, that when you treat patients with SGLT2 inhibitors, there was definitely a signal towards reducing heart failure hospitalization and improved outcomes in heart failure patient populations. And so we had the rationale for why we would look at this in patients with non-reduced ejection fraction as well. And so we undertook a meta-analysis to look at SGLT2 inhibitors in this patient population. And here's a forest plot of the heart failure hospitalization outcome. But as I mentioned, we have similar forest plots for all-cause mortality, cardiovascular mortality, and all of the other secondary outcomes that you would think of. Overall, SGLT use in this population reduced heart failure hospitalization. Well, there was 11 fewer heart failure hospitalizations per 1,000 patients in this population with very strong certainty compared to placebo or standard of care. SGLT2 inhibitors significantly improve functional status and 6-minute walk distance, although not clinically relevant improvement in 6-minute walk distance, and was not associated with worsening adverse events or serious adverse events compared to placebo. So for all of those reasons, we developed a strong recommendation that SGLT2 should be used for people with symptomatic heart failure and an EF of greater than 40% to reduce heart failure hospitalization. Strong recommendation and high quality of evidence. The values and preferences here was really that these benefits far outweighed the potential adverse effects and costs associated with the therapy. We didn't have a lot of evidence to support how patients felt about this and what was their lived experience and how did that inform our recommendation and the cost effectiveness of SGLT2 inhibitors in the Canadian context. You will all be very familiar with prescribing SGLT2 inhibitors because we use them so ubiquitously now in the cardiovascular space, be that with patients who have reduced ejection fraction, those with CV risk factors or established coronary disease, but we do have a whole suite of resources on the CCS website. We did not include the soloist worsening heart failure trial in our meta-analysis, and that was for a couple of reasons. One, because it is a dual SGLT1 and 2 inhibitor. And so we only looked at SGLT1 inhibitors. And at the time, sotagliflozin was not available in Canada. Now, lo and behold, there does appear to be some interest that sotagliflozin will now become available in Canada. And so I want to just talk very briefly about the soloist trial and remind people that this was a trial that was undertaken in patients who were hospitalized, recently discharged from hospital after an acute heart failure exacerbation. The primary endpoint was the total number of deaths from cardiovascular causes, heart failure hospitalizations, and urgent visits for heart failure. The soloist worsening heart failure trial is accompanied by 2 other trials in this space, MPulse using empagliflozin and the DAPA-ACT TIMI 68 trial, which used dapagliflozin. In all of these trials, patients who had acute heart failure were studied. And what we know is that there was positive outcomes in each of these trials for the outcome of recurrent heart failure hospitalization. And interestingly, when you look at a meta-analysis of all of these trials, I'm going to specifically highlight the all-cause mortality outcome here. We see an overall benefit, a significant benefit of the use of SGLT2 inhibitors in this patient population. So while acute heart failure population was not included in the guideline that we published, there was a subset of patients who had an acute heart failure hospitalization and were then initiated on this therapy as outpatients. And we do see a benefit of treatment in this group. So I think we're going to continue to see the evolution of the data in this space and probably an evolution of the recommendation that we made moving forward. Next, to talk to you about MRAs. Again, the rationale is that through a variety of mechanisms, MRAs improve diastolic dysfunction, which is a hallmark of patients who have heart failure with non-reduced ejection fraction. Diastolic dysfunction is common. And this diastolic dysfunction is moderated through the aldosterone receptor on the heart, on the endothelium, and in the kidneys. And so binding of aldosterone to MRA receptors interrupts the cycle related to endothelial dysfunction, myocardial fibrosis, and pathologic cardiac remodeling. There are a number of early randomized clinical trials demonstrating the reduction of cardiovascular deaths and heart failure events in this population. And so that was the underpinning of making of working to develop a recommendation. The two MRAs that we studied in the meta-analysis were eplerenone and spironolactone. And then as we were coming into this, the Fine Arts trial was published as well. So the Fine Arts trial with finerenone. So it was the only non-steroidal MRA that we included. We did two meta-analyses. We did a meta-analysis including Fine Arts, and we did a meta-analysis excluding Fine Arts. And the rationale behind this was there was a lot of controversy in the literature as to whether a non-steroidal MRA was the same thing as a steroidal MRA. So we did the meta-analysis with and without. And what we found when we did the meta-analysis without Fine Arts was that there was very little difference in the relative risk reduction. So with Fine Arts, we saw a hazard ratio of 0.83. Without Fine Arts, we saw a hazard ratio of 0.82. With Fine Arts, we were able to have a better point estimate. And so we elected to include all of the agents as all MRAs, steroidal and non-steroidal together. And so that is the meta-analysis that in itself has subsequently been published. So again, because of the large study population and event rate, the inclusion of the Fine Arts trial improved our precision and therefore the certainty of the evidence compared to placebo. MRA use was associated with reduction in heart failure hospitalization, 29 fewer heart failure hospitalizations per 1,000 patients. There was an increase in hyperkalemia and worsening renal function. However, there was no difference in withdrawal of therapy for adverse events or serious adverse events. So yes, you had more hyperkalemia. Yes, you had more renal dysfunction, but it wasn't a treatment limiting side effect. MRAs did not show improvement in cardiovascular mortality, functional classification, or 6-minute walk distance. You will also note that in the, or remember that in the TOPCAT trial, there were a number of considerations around geography, around sex, and around ejection fraction. And so we undertook evaluation of a number of subgroups with this meta-analysis. And what we were able to see in our analysis is that cardiovascular mortality did not reach statistical significance for subgroup effect according to sex. In TOPCAT, that had been demonstrated. And in TOPCAT, there was also an effect based on LVEF, and we did not demonstrate that in our meta-analysis. So, strong recommendation for the use of MRAs in people with symptomatic heart failure and an ejection fraction of greater than 40% to reduce the risk of heart failure hospitalization. The values and preferences listed there, and the further studies needed listed as well. I won't read them out for you. Lo and behold, timing is everything. shortly after we published the guideline in October. By December, finerenone had CDA recommendation for reimbursement. And so now finerenone available for the management of patients with an EF of greater than 40%. Again, I will remind you that finerenone is a non-steroidal mineralocorticoid receptor antagonist that is more selective than spironolactone or eplerenone. It's highly potent, and you can see some of the different pharmacological properties listed on that slide. And it has more balanced effects on the heart and on the kidney compared to the steroidal MRAs, eplerenone and spironolactone. Very effective in the fine arts trial in terms of reducing cardiovascular death and total heart failure events, but this was driven almost exclusively by a reduction in heart failure events as compared to cardiovascular death. So the primary endpoint driven by first and recurrent heart failure events, the significant reduction. But I will draw your attention to the ISAR. So this is from Cadith, looking at the incremental cost-effective ratio for per quality adjusted life year. And you can see that finerenone has an ISAR of about $77,000 for one quality adjusted life year. And this is sort of the spectrum of economic value, with the value decreasing as the ISAR increases. We typically think of hemodialysis as being sort of the gold standard in and around 50,000 per quality. And so you can see where finerenone lands on that and make your clinical judgments accordingly, recognizing that the meta-analysis shows no difference between steroidal and non-steroidal MRAs in terms of improving outcomes in this patient population. Number of practical tips accompanying the guideline. These are very similar for spironolactone and eplerenone, except for the eGFR cutoffs. You will know, of course, in using MRAs that we need to be thoughtful about measuring renal function and electrolytes 1 week after initiation and dose changes. Finerenone may specifically have value in those patients with diabetic kidney disease, which is beyond what I'm going to talk about today, but we do have data from the Figaro and Fidelio trials that show patients with diabetic kidney disease also have decrease in terms of renal progression, as well as improvement in cardiovascular outcomes when treated with finerenone as the MRA of choice. Here's the titration schedule and some tips and tricks around that, which I won't go into any great detail with, but again, lots of tools at the CCS to support practice integration. So I think there are a couple of things that we do need to consider as we move forward and integrate MRAs into our clinical practice. And that is really to understand the cost effectiveness of finerenone in the Canadian context as it relates to treatment of patients with heart failure with non-reduced ejection fraction. We really would like to see some head-to-head trials of the steroidal and non-steroidal MRAs, and then looking at combination therapies, and there's some work underway to look at MRAs with SGLT2 inhibitors to reduce hyperkalemia, which of course is one of the things that we look to avoid in this patient population. Moving along, ARNIs. We know that ARNIs block angiotensin II receptors and increase natriuretic peptide levels in patients with heart failure generally. They have been shown to affect cardiac remodeling in a positive way and enhance cardiomyocyte survival. They've been shown in patients with reduced ejection fraction to improve all the important clinical outcomes that we would think of, including heart failure hospitalization and symptom burden. Notably, there aren't trials in patients with an ejection fraction of greater than 40% that cover the whole span of EF of 40 to 60%. And so this group, while of interest, there wasn't per se a single clinical trial. And our meta-analysis was really looking at subgroup analysis, post hoc subgroup analyses of patients with EF of greater than 40%. We included 4 trials in this group. And what we were able to demonstrate was a small reduction in heart failure hospitalization. 20 fewer heart failure hospitalizations per 1,000 patients with the confidence interval shown there, but no reduction in the other important outcomes that we would be interested in, such as heart failure hospitalization, functional capacity, or quality of life. You will recall that in Paragon, the Paragon heart failure trial, pre-specified subgroup analysis suggested that there might be differences in the effect of ARNI on the basis of LVEF and sex. In our subgroups, there was a better reduction in heart failure hospitalization in women, but the treatment effect was consistent across all LVEF subgroups. So again, I started off the top trying to compel you that there was no real rationale for breaking this group up into mildly reduced ejection fraction and preserved ejection fraction. What we saw across all of our meta-analyses, subgroup analysis, was that ejection fraction really didn't attenuate the benefit, and we saw this with ARNI as well. So whether you had an EF of 41% or an EF of 59%, you were still receiving the same degree of benefit from the therapy. Again, raising the question, why separate these into the mildly reduced and preserved group? If the benefit you see is consistent across the entire EF spectrum, then let's just lump the whole group together to improve the ease of prescribing and to ensure that there's better clarity in terms of the benefits that this patient population receives. What we did show, though, when treating patients with ARNI, is that there was increased risk of hypotension and increased risk of angioedema, as one would expect. There were equivalent rates of hyperkalemia and worsening renal function. And so that the recommendation that we make really does take into account this piece around hypotension, and to ensure that you're prescribing it in patients who are at low risk of symptomatic hypotension, which we define as a blood pressure of less than 100. This is a weaker recommendation because, as I said, we were looking at subgroups and post hoc analysis, and there wasn't a single clinical trial that looked at all of this, this continuum of patients with an EF greater than 40%. One important note. Patients who were frail in the clinical trials actually received greater benefit from this therapy. So I know that we talk a lot about frailty as a barrier to heart failure therapy, and specifically around ARNI because of the concerns around hypotension. But in clinical trials, patients with frailty actually performed better and received more benefit from ARNI than placebo. A number of practical tips to consider when prescribing these therapies. Again, you really want to think about how you can mitigate hypotension and volume depletion. And so considering and reducing other therapies which are associated with hypotension, which may not have benefit in heart failure patient populations, considering stopping or decreasing diuretics, for example. And then there is finally one thing that I do want to draw attention to, and that is in patients who won't tolerate an ARNI for whatever reason. The angiotensin receptor blocker of choice is candesartan per previous guideline recommendations, and that's largely based on historic data from the CHARM preserved trial. Cost effectiveness is really the big future consideration that we need to think about in this group, and there is being a cost-effective analysis done in the US and less robust ones done in the Canadian population. We think that at the wholesale discounted price that you would receive for an ARNI in Canada, that it is a cost-effective therapy, particularly for people with an EF of less than 50%, but we still need to really look at it across the full spectrum of the HEF and REF population. Finally, I'm going to touch on GLP-1 receptor agonists. We know that they impact cardiovascular risk and that there's a high risk burden in those patients with heart failure non-reduced ejection fraction. 80% are obese and 1/3 have diabetes. So we know that these therapies have benefit in diabetic patients. We know these therapies have benefit in obese patients. And so we hypothesize that they will have benefit in those with heart failure with non-reduced ejection fraction. We know that visceral adipose and we know that epicardial adipose, through a variety of mechanisms, can result in worsening of the heart failure phenotype. And so there is physiologic and biologic plausibility that these patients would benefit from this treatment. GLP-1s were studied in the STEP-HFpEF trial and the STEP-HFpEF diabetes trial. And those were really the two groups that we looked at in our meta-analysis. In those trials, patients were included if they had an EF of greater than 45%. And our meta-analysis of this group fell in line with the previous meta-analysis of those two trials, showing 52 fewer heart failure hospitalizations per 1,000 patients. There was also an improvement in heart failure related health status, as defined by the Kansas City Cardiomyopathy OSS score. But there was no difference or improvement in overall mortality or CV mortality, and no increase in adverse events. No heterogeneity or significant interactions in subgroups. So this was very consistent with what was already available in the literature at the time. We did not include data from the SUMMIT trial. The SUMMIT trial was published during or shortly after the guidelines were being developed. And the SUMMIT trial included tirzepatide, as you all know, which is both a GLP-1 receptor and GIP receptor agonist. So slightly different physiology. But tirzepatide in the SUMMIT trial did show a 38% relative risk reduction in time to first occurrence of heart failure outcomes. So really impactful. And the heart failure outcomes were an urgent heart failure visit, a hospitalization, or an oral diuretic intensification. So a slightly different outcome, but very impactful in terms of reducing heart failure outcomes. It also improved all the secondary endpoints you would be interested in, including functional capacity and weight, as well as CRP. So we really do think that there is going to be an evolution of this recommendation to include other types of GLP-1 receptor agonists and other molecules in this space. But for now, we have a weak recommendation based on the fact that this, again, is subgroup analysis and retrospective, but the GLP-1s should be used in this patient population with an EF of greater than 45% and a BMI of greater than 30 to reduce heart failure hospitalization. And as I said, there are a number of molecules and indications for GLP-1s that are coming down the pike. And so once again, we expect iteration of this recommendation moving forward. And hopefully what we'll see is that it moves from a weak recommendation to a strong recommendation with more focused and robust information. For the clinician, I think it's really important that we now begin to embrace in the heart failure space dialogue with our patients related to weight modification and obesity. It's a conversation that I'm not historically used to having, but I've needed to familiarize myself with this conversation and how I can support my patients. And I would direct folks to Obesity Canada guidelines and the 5 A's for working through this and familiarizing myself with, again, how to support my patients and what resources are available to support my patients. The guidelines provide very practical tips in terms of initiation and titration of these medications, which we know is important to improve tolerability. And here are future considerations, as I said, really trying to understand why patients are benefiting from this. Is it weight loss per se, or are there other mechanisms by which these therapies benefit our patients, and whether they would be of benefit in non-obese patients as well. So, in summary, that was a lot of data. We really believe that this guideline offers potential to significantly improve outcomes in a patient population that has largely been misunderstood or not understood, and for which there wasn't a lot of therapy to offer in the past. They have poor prognoses, they have poor quality of life, and it's really going to be important to introduce guidelines to support their care. There are 4 therapies we now know that have good clinical trial evidence and can be integrated into algorithms to improve patient management. We really encourage this type of structured approach because we know that it improves prescribing and it improves therapy for our patients. But there is much knowledge that still needs to be garnered. There were 4 recommendations offered, 4 key recommendations offered in this guideline. The 2 listed in green are strong recommendations and will form the first tier of initiation of therapy for our patient population of interest. And then Once those are initiated, we're going to be looking to 2 other therapies in subgroups of patients, those who have reasonable blood pressure and those with an EF of greater than 45% and who are obese, and initiation of additional therapies based on those phenotypes. We already have good data to show that layering on therapies has summative effects in terms of outcomes. And so this is a really elegant work from Vaduganathan in Nature Medicine, which just looks at 3 of the 4 therapies that I talked about. That is SGLT2 inhibitors, non-steroidal MRAs, and ARNIs, and looking at their cumulative effect in patients with an ejection fraction of less than 60, but fall within this mildly reduced and preserved group. And you can see a 39% relative risk reduction in favoring combination therapy to try and modify the endpoint of cardiovascular death and worsening heart failure, let alone if you add on an let alone if you add on a GLP-1 receptor agonist. So these are additive, summative effects with real impact for our patients. And so with that, I'm gonna end and just again remind you of this central figure, encourage you to make yourselves familiar with it, remind you of the 4 therapies, but also draw your attention to disparities amongst patients who may not have access to this therapy. Final shout out this weekend or coming up is Heart Failure Update in Montreal, supported by the Canadian Heart Failure Society and the Canadian Cardiovascular Society. I would be remiss if I walked off stage here without again drawing your attention to all the knowledge translation tools and the guidelines through the Canadian Cardiovascular Society website. I'm here in Ottawa, which is the home of the CCS, and make a big shout out to the CCS. Encourage you all to engage, to become members and engage with the CCS through any number of ways as a trainee, as a full member, participate in any of our committees, the board. We have Congress here in Ottawa this year, which we're very excited about, and specifically the partnership that we have with the University of Ottawa Heart Institute. We do so much collaborative work together. The UOHI has been a leader in the cardiovascular space in Canada. So I'm honored to be here, both to speak, to represent the Canadian Cardiovascular Society, and to say a big heartfelt thank you to all of you and your leadership, David, Rob, for partnering with the CCS in all of its work. And with that, thank you. Happy to entertain any questions.
Thank you, Sean. Does anyone have any questions? If you do, come on up to this, or you want me to be Oprah Merdad and actually walk over there? Yeah, no, it's okay. I'll walk over. I'll be Oprah. Dr. Golian.
Thank you for the review. It was great. Quick question about Finerenone. Considering the ISIS cost that you showed, and knowing that the benefit is a little bit more questionable in terms of the meta-analysis, looked very definitive, but when you look at SPIRIT-HF and TOPCAT trial, the studies were, you have to do a subgroup to take a look and make sure that you find a benefit. In your practice, if you get a patient like this, do you go for the more expensive drug, or do you go for the, steroid one?
I go for the drug that's cheap and effective and available.
And then that in the guidelines, is there a recommendation for the general person that reads this? And you're going to get a lot of industry reps presenting their data, comparing it to TOPCAT, comparing it to SPIRIT-HF. Is that also reflected in the guidelines in terms of what
it is reflect? So the guidelines came out before SPIRIT-HF, but to be honest, I don't know that SPIRIT-HF really moved the dial on much, just because of the quality of the study. And so it does specifically reference this in the guideline, and we call out the diabetic kidney disease group because I think that's a slightly different group, and there is more data to support that, to support Finerenone in there. But yeah, we're pretty prescriptive in the guideline, and make reference to the fact that in the absence of any meaningful difference in terms of the meta-analysis, and really being thoughtful about doing two meta-analysis with and without fine arts and comparing that and seeing no difference, that we don't have any compelling reason for, in the general non-reduced ejection fraction group, to be using a more expensive agent.
Great, thank you.
Yeah, so Sean, this is fantastic work, really continuing the tradition, really top-notch evidence-based guidelines, for Canadian Cardiovascular Society. And, I think I mentioned yesterday, in fact, the Canadian guidelines are very much, highly referenced, worldwide, so this is fantastic work. I guess there's a couple reflections. One is the fact that certainly when we did the heart failure guidelines earlier, there was actually nothing, for heart failure was non-reduced ejection fraction. At least now we have something. But I guess the two things that's still important, I think, some of the points are well illustrated here, is that a lot of the patients, with HFnERF, is actually in the primary care. It's actually not in the cardiology domain, or they are underdiagnosed or wrongly diagnosed, right? So certainly for us, quite often we actually have a patient come in, but end up, having amyloid or other type of conditions that may masquerade as HFpEF or HFnERF. And so I think that's one thing. And then keeping it really simple is important, because I'm worried that a lot of our primary care folks, because our experience before is that the wonderful guidelines we have are really complex, for primary care, so really simplify the approach. So for example, just the SGLT2 MRAs, probably actually go a long way, for the population. But we still have a long way to go, because we really are great in terms of reducing hospitalization, but trying to impact on mortality for this population, so we still have that. Looking for those magic combinations. Yeah. So thanks so much for great work.
Thanks, Peter. I think one of the things for me that's really exciting about this is you now have a patient that presents to an emergency room with a first presentation, or to a GP's office. First presentation heart failure, let's say it's confirmed with a BNP. Historically, we were stuck saying, I can't really do more for you other than diuretic therapy until I get an echo, because my treatment is going to be very much directed by what your ejection fraction is. Now, patient shows up in the emergency room, and I can initiate them on an MRA and an SGLT2 inhibitor and know that I'm impacting their heart failure, irrespective of what their ejection fraction is going to be. And so you can now, it'll take, I don't know how long it takes to get an echo in Ottawa and Vancouver. It can take a couple of months at least to get an echocardiogram if you're a GP ordering one from your office. And so, you've got this opportunity or this window where a patient really isn't getting any therapy. Now, at least you can begin to treat them much like we do now with atrial fibrillation in the emergency room with new onset. Here is an anticoagulant of some type. Here is a beta blocker. Off you go and follow up in AFib clinic. We can now say, here's your SGLT2 and MRA, follow up in heart failure clinic. And I think that's a really interesting change and a real advance for how we treat risk in this patient population.
Thank you very much for coming here and giving this talk. It's great. Although not specifically these guidelines, like what are your feelings or your opinion about the meds that should be given for the patient who's sitting with the ejection fraction of 40 to 50% who is not having symptoms?
Yeah, it's a really good question. I mean, in my practice, if you've got EF of 50%, incidental finding, and you're referred on to cardiologists for incidental finding, your functional class 1, I would probably hang my treatment on whether the patient had elevated NP level, natriuretic peptide levels. So if the patient's NP levels were less than 300, I would probably not treat them. If they were higher than that, like I'm really looking for something to hang my hat on in terms of saying you are pre-symptomatic. But if we were really by the letter of the law, all of these trials were done in patients who had symptoms. None of them were in asymptomatic LV dysfunction. So I'm really looking for, please compel me that you're not truly NYHA1. Please compel me that you have a slightly elevated natriuretic peptide level. But if all of that was truly absent, I really wouldn't have much rationale for, or
And when
clinical trial rationale for.
and when they're down at 40 to 45%, are you not treating these people with anything?
I mean, as
Or
I said, I'm
just
I'm
from
looking
your
desperately for it.
how you're managing them.
Yeah, I'm looking desperately to try find some reason to treat them. Do you have mild coronary artery disease that I can give you an SGLT2 inhibitor for? Do you have hypertension that I can treat you with an MRA for? Those are sort of, I'm really looking for some reason to treat them with these therapies.
Thanks.
Yeah.
Hey, thanks so much for the talk. I was looking at the Spirit HF trial, and I just want to touch upon it as well. I was kind of disappointed with some of the results. I know there's concerns about it being like during the COVID pandemic, but overall, I just felt like there wasn't even that signal towards benefit. And then we had those renal concerns. I was curious, how do you approach that trial in modern heart failure? And
I mean, to be honest, I don't really approach that. I mean, I think methodologically, and it was stopped early. It was done during COVID. Like, I think that it doesn't advance us in a way. It doesn't provide evidence that's going to help us come to a definitive decision about the best strategy for MRAs in this patient population. So, to be honest, I don't think about it much.
thank you.
Yeah.
One final question from me. So just a clinical scenario, and I'd like to know sort of how you would tackle it. So you have a patient with a Titin gene mutation with an EF of 42%. New diagnosis, not on any therapy yet. Would you start a beta blocker?
It's a good question. Probably more because of arrhythmic risk than EF. Probably. What would you do?
Yeah, I would. Yeah, I would, because I don't know. I think, and I asked this question more so for the house staff actually in the room, because I think in my mind anyways, and this is just experiential, it's not trial driven. The patient with an EF of 40 or 41% in my mind is markedly different than the patient that's got an EF of 52, 55, the hypertensive elderly woman with diabetes, obesity, whatever. Like, that's a different cohort in my mind than, the patient with an EF of 40, 42%, with perhaps a genetic cardiomyopathy, something like that. Like, these are different patient populations in my mind. And so in the latter with the 40%, yeah, I would probably treat them more as a half ref, if you will, even though technically, their EF is, in this range. Yeah.
And the natural history of that disease, right? It's not going to stay 42 for long. So, get on the treatment. It is interesting. We get asked a lot about beta blockers in the greater than 40% patient population. And there's no real good study of that yet. Like, really high utilization of beta blockers in this group. It's like 80% plus. Oftentimes because of the comorbidity burden. So they've got coronary disease, they've got atrial fibrillation, they've got some other indication for a beta blocker. So we see it quite often used, even though there isn't a clinical trial to support it.
That's great. Thank you so much, Dr. Virani, for coming to present today. Thank you, everyone, for attending. Please come back to rounds next week. Have a good day.